we found this guy wandering the halls of the hotel aimlessly, and he said he was a doctor. So he said we invited him in, and he said his name was Mel Herbert. You know a guy by the name of Mel Herbert?
Hey, how you doing?
Mel is the father of MRAP and all of the spin-offs of MRAP, and we're delighted that he's here.
He's the guy I showed you who was juggling in a good way.
Call me a mother of MRAP. Just a mother, usually.
All right.
Q&A.
So we got a lot of questions this round. We'll try to get to as many as we can.
She'll read them.
All right. Now, the first question here, it states on slide 10, and this was the lecture for about blood pressure.
Vital signs.
Yeah, vital signs, blood pressure and vital signs. And on slide 10, to not treat blood pressure unless urgent need. Treat if symptomatic. I have had several patients not only in the ER but urgent care that come in, their BP was elevated, and they have either no history or just haven't taken BP med. When do we give meds, Diane?
So I'm going to defer this question because this afternoon we have a whole talk on hypertension and syncope. The bottom line is, again, do no harm. You're not going to buff a number, and we'll get into some specifics on what actually constitutes hypertension. A single measurement in the ER doesn't constitute hypertension. So we'll talk about that. And I don't mean to be rude, but there's a whole talk on that. So.
Excellent. Okay, just so we know.
It's coming.
It had the most likes, so I just wanted to make sure you knew we were getting there.
Yeah, I promise.
There's going to be no topic unturned after this 3.5 days. Nothing.
Billy, can you repeat your phrase, please?
Diaphragm alive.
For the
Oh yeah,
record.
C3, 4, and 5 keeps the diaphragm alive. That's really important when you see someone who's had a C-spine fracture, because if their fracture is high enough, into C3, 4, and 5, they may not be able to breathe. So you'll see things like belly breathing and such like that. So that part of it's pretty important for airway management in C-spine fractures. Remember, the dermatome for C3, 4, and 5 is your shoulder, and that's why when you have subdiaphragmatic pain, like with a ruptured spleen, you get left shoulder pain. That's Kerr's sign, because that's the dermatome for C3, 4, and 5, which is going, to your diaphragm. Similarly, on the other side, if you had Fitzhugh-Curtis with perihepatitis, we don't see much of that anymore because GC's, sort of on a backtrack, but you might get shoulder pain with that as well. And then S2, 3, and 4 keeps the shit off the floor, is about sphincteric tone and the ability to control that in terms of the conversation of bowel and bladder incontinence. And so it's low and sacral with regards to that.
Okay. Next question, still for you. What about prednisone for back pain?
So steroids, and it's not, I'm not throwing any stones at anyone who's given a Medrol dose pack. Certainly I've been guilty. When you're dealing with a patient who's very frustrated and they've already maybe been through some of the pharmacologic choices that you'd have, and you're trying to avoid maybe more opiates, you might do this. But the literature on the topic is not particularly compelling. Like many of the topics that are out there in the musculoskeletal world, the literature's not of high quality and not really compelling. A lot of neurosurgeons will do it when they see people, so you'll refer them and then they'll do that. But for much of back pain, the inflammatory, steroids work best when there's a prominent inflammatory component. And for a lot of these are mechanical pinching, not that inflammatory. Chronic ligamentous thickening and things like that, not that inflammatory. And so I'm hesitant to do it, and I also want to look carefully in terms of whether if I was going to fall back to that route, is it a diabetic? Is someone who's going to have other complications? Is it someone who's had a GI bleed recently and is already on low-dose aspirin? Sure, let me give you some steroids, and there's nothing to make you forget your low back pain like a GI bleed. So I'm hesitant with it in general. I'm sure there are others that have opinions here.
I think patients like doing something when they have back pain, and it's hard for them to say, well, it's going to get better with time. So their idea is, you could rub stuff on. Ben Gay, he's got a little salicylate. That's good. You know, they sell now TENS units.
Talked about that at length.
$25, $30. You can put that thing on. So it's not like you're not doing anything. We're just doing a variety of things, and I think it's good for their head to know that we're actively trying to do something.
And Martha, I saw another question about muscle relaxants and things with the elderly. And we didn't have time in that conversation to go through all of the strategies for the different age groups. I am cautious with elderly. Remember, the best muscle relaxant there is really is Valium. And we know that if you take elderly populations and put them on opiates and Valium, what do you see them back for?
Hip fracture.
Hip fractures, subdurals, a variety of issues there. We've reviewed some papers in the abstracts that say just a single prescription for a sedative hypnotic, someone's got a comment, sedative hypnotic or an opiate in the elderly really like doubles to triples their risk of a hip fracture.
I think Jim Jim, you want to say something about Valium?
The abstract would say just a single prescription for a sedative.
What's going on, Dr. Google?
Elderly.
I don't think he's got our audio. That's okay. Mel, you had something to say particularly about steroids?
Well, just for back pain in general, 20 years ago, I worked on the AHRQ governmental panel on back pain, and 20 years ago, nothing worked for back pain. And today, nothing works for back pain. So you can try all the stuff that doesn't hurt patients is fine, put on a little Bengay and do all this stuff, but when it comes to things like steroids, when you know full well that it is very, very unlikely to make a difference, but has a very good chance of hurting them, you have to think twice about giving it. So I'm really worried about steroids out of that whole list, but also Valium and stuff as well. It really has never been shown to work. People don't want to hear that. They want something, and unfortunately all you can offer them is time.
Billy, did you mention physical therapy?
Yeah, I talked to there. It was on the slides. I mentioned that physical therapy and those types of things, NSAID, stretching. You know, whether you want to do those things. Certainly, there's a lot of visits involved, and so there's some attention to that, which I think patients like having that. And I think it's a very sort of individualized thing in terms of how much benefit is yielded. You know, there's an infamous paper also in the database for the abstracts where the title is Untampered Low Back Pain, where they basically say what Mel just said, which is doing nothing and telling you it's going to last 4 to 6 weeks is as good as anything.
Yeah, but don't have people go to bed. Like, they have to like live. They have to move around and.
Yeah, but
bed
you
rest
doing
is-
nothing, not them
Yes.
doing nothing.
Yes.
They should ambulate and walk as
Yeah,
tolerated.
yeah, definitely.
We talked a little bit yesterday about setting your patient up for success, and I think Mel makes a really good point that you kind of have to give them a time frame. They want to know when they're going to feel better, and you're going to say you're not going to feel better tomorrow. Your pain level's not going to get down to a 0. So kind of just put things in perspective.
I think
for them.
that's important. I was actually I've been flying a lot lately on a really, really bumpy flight recently. I hate flying anyway, but really, and God bless the flight attendant who came up and said, it's 5 more minutes. Just hang in there, it's 5 more minutes. And suddenly it was like, oh, okay, I can do this for 5 more minutes.
Exactly.
Yeah,
But
really
I think there are
important.
2 places where we sort of fib to patients a lot. One is when they have a URI and a cough, and the other is low back pain. When you look at the data on URI and a cough, that's a 3 to 4 week illness. We may treat them for a week during the worst part of it, but the idea that if you sell them, they'll be better in a week, they're not going to be. If it's a viral URI, they're going to have, 3-4 weeks of coughing, and they should expect that. And not setting the expectations right gets them to come back. So then they started on a Z-Pack that they didn't need. Now they're on some cephala, whatever, that's like $175, and it'll give them C. diff. Because it's not better in a week. We have to set the right expectations. So URIs, that's a 3-week illness. Low back pain is a 4 to 6 week illness, minimum.
Yeah, because then they come back because
Right.
someone told them you'll be better in a week, and they come back saying, well, I wasn't better, and my discharge instructions said I should come back, so I'm back. And you still have nothing to offer them. Same with the cough. Like, there's nothing good to offer for cough, really, either. And now you're kind of stuck. So
Yeah,
I think
I
that
thought-
expectation really helps.
I touched on that, I think yesterday about the ethical responsibility that you have to not pawn them off on somebody when it's inappropriate. You can't say go see your follow-up doctor in 3 days when you have back pain, musculoskeletal, clear cut, or you've got some bronchitis. And so you basically it's only fair to the patients that they have the expectation of how long this is going to last.
Billy, do you still tell them what you used to tell me to tell them, which is it's your own fault for being a biped? You know, if you walked on all fours like we were supposed to, you don't get back pain.
No, I did mention, though, that it is a disease that comes from walking on your hind legs. And you know, the back, your lower back in particular, is an excellent example of unintelligent design. Your back wasn't really made for bipedal locomotion. We're somewhere in the couple million year process of getting to a place where it might be better evolved for that. But you know, four-legged animals don't get low back pain.
So you can tell people to wait for evolution and
Yeah,
they'll go
they'll
away.
catch up. We're living longer. Maybe you'll get there. Yeah.
All right, this sort of leads me into the next question about viscous lidocaine. And I had commented, it said, what was the age cutoff for viscous lidocaine? And I said, just don't give it ever, okay? For pharyngitis, for canker sores, things like that. The people that are getting viscous lidocaine in my treatment are people with cancers and have failed all other treatments. And I don't know what the rest of the panel has to think about this, but there are a lot of other better interventions for a sore throat than viscous lidocaine, especially in kids who can swallow it and reach toxic levels.
I don't tend to give viscous lidocaine, but I don't know, every once in a while. I mean, if you think about if I had something terrible going on in my mouth, or maybe a sore throat, I might try it personally, but I agree with you that if you have someone that can't really follow instructions or, you know, you don't think is going to be able to be reliable, then I'd think twice. It might be helpful for some things. You know, terrible recalcitrant sores in the mouth, things like that, where a local analgesic would be useful for sure. For just pharyngitis, you know, there are other options.
I'm not a never, but I'm much more, for oral stuff, I'm more into them dipping a
Yeah.
Q-tip into it
Yeah.
in direct application
exactly.
than swallowing it.
Yeah.
And then I will also admit to the sort of low-budget process of when someone has severe epigastric pain that sounds like gastritis, where I want them to swallow it, an adult,
Yeah.
I'm okay with, you know, I don't over-rely on the effective treatment for telling me what it is as a diagnostic thing. But I love the green goddess, a little Donatol, liquid Donatol, the green stuff,
Showing
a
your
little
age.
viscous lidocaine, a little, Maalox. I love that for someone with severe epigastric pain where I'm just trying to settle it down and see where we get. But, you know, there you go.
But just for your pharyngitis or even hand, foot, and mouth, don't be giving the kids the viscous lidocaine. Try some other interventions first.
Neb lidocaine
And-
works a lot better.
And we talked about Decadron as being an intervention as well. So if you're going to get them to put something in their mouth and, what did we say yesterday, squirt it down their throat, you know?
Yeah.
That's the one. Okay. Seeing a lot of pars fractures. Can you speak to that?
Yeah. So a lot of it is that we're imaging a lot more
Right.
people and finding pars fractures that were always there and we didn't find. So remember, as you look at the spine, there's the body, then there's the pedicles, right, and there's the canal, and then the last sort of the roof of the TP are the pars intraarticularis. This typically, when you're talking about pars fractures, you're talking about spondylolysis. Spondylolysis is the recurrent stress fracture of the pars, and then when it slips, it's the spondylolisthesis. But I think we're investigating a lot, and they're often referred to in the setting of spondylolysis as a sort of a stress fracture from, again, hyperextension. We were talking about hyperextension in young athletes, gymnastics, ballet, cheerleading, all kinds of sports, even reaching over your head where you arch your back for an overhead serve in tennis, things like that, and then you're harnessing all those muscles to try and hit that serve as much as you can. But those can cause these recurrent stress fractures. That's very different and is a chronic form of pain in the back than someone who has an acute traumatic injury, where you can also obviously get pars fractures in acute trauma, but understand those are different things. But in both cases, we're finding a lot more of them because we're doing three-dimensional imaging, right? So CAT scans and such. And the other thing I will say, they rarely need surgical intervention, even when they're acute traumatic. They rarely need surgical intervention. You may need to call a consultant, but they rarely get repaired mechanically. When you talk about spondylolisthesis, there's a grading, grade 1, grade 2, how much has it slipped? And in some people, once it's grade 2 or grade 3, they'll talk about whether or not they want to do something. But the vast majority you're going to encounter are grade 1, a small amount of slippage, and most of those are managed conservatively without it. But in terms of the number of pars fractures you're finding, I think they were always there, but we're finding a lot more of them because we're doing CT scans a lot more frequently than we used to.
Okay. So, Jim, were you using Nystatin when you were changing my diapers? What were you using? I think it's still okay to use Nystatin. So,
The number
that's,
of
He didn't change your diapers.
Wait a minute, you didn't change my diapers. I take that back.
That's why you got
I might,
dermatitis.
might be changing yours soon, though.
Yeah, you'll get to answer that question yourself shortly.
Shoot, we're gonna have to come to a decision here. What are we using?
I think this is a really interesting question. I want to know what these guys think. Of course.
I think.
Go ahead, Jim. You got to turn the live feed off.
Yeah.
Yeah. You'll get to answer that question yourself, Jordan.
Okay, sorry. We're just having a little technical difficulties with that. Apologies.
That's more than a little.
We are
That's a
under our
lot.
control.
Yeah.
So diaper dermatitis is caused by sitting in your own urine for too long, which is disgusting. Candida, and it can become cellulitic.
What does Canada have to do with this? We have some Canadians in here.
And they're all red, and they all look the same.
Your mic's off.
Your mic's off.
My mic is dead. They're all red. They all look the same. So a lot of the time you can't tell. So I think some combo of treating all of those things, or just changing the diaper more frequently makes it dry, and that'll kill the fungus. It'll fix lots of things. But I don't know. When you look down those red diapers, can you tell the difference between what the hell caused it?
Yeah,
No,
I think you can tell a lot of
satellite
kinds of
lesions.
lesions.
Yeah,
If there's
satellite
satellite lesions, that speckling of real red spots around it, that's pretty convincing evidence that it's fungal. And then you have to remember your basic rules of dermatology. And the first rule of dermatology is if it's wet, dry it.
Right.
If it's dry, wet it.
Dry,
That's
clean,
the
and
first rule of
breeze.
dermatology. The second rule of dermatologists, while we're on the topic, is if you know what it is, why would you touch it? If you don't know what it is, don't touch it. Either way, don't touch it without gloves. Those are the two rules of dermatology that will help you avoid getting herpes somewhere on your body from their body. But drying it will often solve the problem with diaper dermatitis, because if it's wet, dry it. So that's where you get into open airing the kid, frog legging them more, because the fungus won't grow there. I got no problem with using an antifungal on this in low doses if it looks nasty. And I don't care if it's Nystatin or some other one. But all topical antifungals are going to be equally effective for shallow topical dermatitis type problems. Remember, once a fungus becomes deeper, for example in a nail bed, then the topicals are really not going to work as well. And once it becomes tissue bound, like in sporotrichosis or in a carrion, then you need to use oral agents, and you need to watch liver functions and all that crap. And if it becomes systemic, like in an HIV patient who has maybe histoplasmosis or coccidiomycosis or things like that, then you got to go to IV. But for all of the topical things, tinea crura, diaper dermatitis, tinea capitis, these are all topical antifungal treatments, and they all work fine. I would pay most attention to cost rather than to the name of the product.
Yep.
And drying it is the key thing. If it's wet, dry it. If it's dry, wet it.
All right, so just to clarify, if I misspoke earlier, I apologize. So the question is it 7 to 10 weeks, like I said, or 7 to 10 years to get subacute sclerosing panencephalitis after measles? So what you need to know about this is that they get better. And there have been cases where it happens weeks after their cases of measles, up to 27 years after cases of their measles. So just to clarify
But
that.
the majority are weeks.
Yeah.
But yes, the majority are weeks, and I just wanted to clarify that. So that's that. Oh, and we answered this one in Slido, but Jan, should all vaginal bleeds have a pelvic exam?
So I think the answer is mostly yes. I think there are probably some circumstances where you never say always, never say never.
Right.
I wouldn't say always. I can think of some circumstances where maybe it wouldn't be indicated. For the most part, though, I would think the default answer is yes. And I'll give you some reasons why. Number one, there are things that you can see on your exam that are important to find. So, for example, a cervical cancer that could be bleeding would be important. And a lot of the patients we see are not going to regular doctors all the time. So that would be something important. There are things like trauma that you can find in a patient who's having vaginal bleeding. Now, could you have history of that? Sure. But there's reasons to look. For the most part, I think it's an important part of the exam. I think it adds something to the exam. It gives you more information. It gives you an idea of how much bleeding there is. So for the more most part, I would say yes. Are there circumstances where I haven't done one? Sure. So I think that there are some individual caveats to this, but for the most part, I would, and I want to hear what Diane has to say, because I know we've argued this before on the panel as well.
Yeah, I mean, the only time I really wouldn't is if they've already had an ultrasound.
Yeah.
So if I already know what's there, and even then, I don't know what the cervix looks like very
ultrasound
well.
doesn't always find cervix.
It doesn't. No, it
cervix
absolutely
pathology.
doesn't. Or if the patient just says, I don't want it.
Yeah.
I really, really, really don't want it. And a lot of women, when given the option, which that's part of what you should do in your job, they say, I don't. I really don't want that. And I get it. But I think I think it's indefensible to not have looked there and to have something happen down the line that you could have picked up if you'd just taken that extra time. I think it's indefensible to not have taken the time. So,
I'm
not legally,
a
just like
believer
ethically.
of examning the chief complaint body part.
Yeah, me too.
And if the chief complaint is vaginal bleeding, I think that means an exam. And cervical cancer is a killer of young women, and you can't find that on ultrasound most of the time.
No.
And so I'm a big believer, my line when I'm talking and working with residents, I'm a big believer of your retina on her cervix.
Nor should you be ordering an ultrasound in every patient
Right.
who has
Exactly.
vaginal
Absolutely.
bleeding. So
Right.
I wouldn't order the ultrasound
Absolutely.
to get away with not doing it in some circumstances. But I agree.
Surprise foreign bodies get found.
Yeah, that one.
That's a bad thing to miss, a surprise foreign
But
body.
multiple retinas on the women's area should be avoided. So if
Agreed.
you know that your
Yeah, yeah.
OBGYN...
That's why I say
Yeah.
there could be circumstances
So-
that I can imagine where she's going to the next day or the same day
Exactly.
to see her doctor. I wouldn't put someone through 2 pelvic exams when it doesn't seem necessary.
Right.
So there are circumstances. You could give me a vignette where I'd say, no, I wouldn't do it.
Yeah.
But I just want to encourage people to not, as a default, think that you shouldn't do it or you don't need to do it.
And I think it's okay if you talk to your OBGYN and they're in-house and it's their patient there and they say, I want to come down and see this patient, did you do a pelvic
Nothing
exam?
could make me happier.
So just say, no, I held off on doing the pelvic exam because I knew you were here and the patient, had already talked to you. So that's a situation where you could.
Exactly.
There was a comment
Yes,
over here.
Yes.
You still got it?
Early pregnancy,
early
right.
pregnancy.
So this is, I think, what Diane is referring to, which is, let's say that the ultrasound got done before you even got a chance to do the exam. You have your ultrasound result back, and now you're kind of in a circumstance where you're asking yourself, what is the pelvic exam really going to add to what I already know from the ultrasound? And again, it kind of depends on what the ultrasound shows and, what the possibilities are. I can see a scenario where there could be some shared decision-making about, this is what the ultrasound shows. It looks like you have an intrauterine pregnancy. You have a little bit of bleeding. You're otherwise stable. What I would be looking for would be to see if your os is open or closed. These are the things I'd be looking for. And often they would say, I'd prefer to defer it. I'm going to go see my OB tomorrow, or I have an appointment in a couple days, and that's fine. So I can imagine that there are circumstances where you could create a story where you don't need to, but there are circumstances in there where I would say you do need to, especially, let's say one circumstance is if she's having a lot of pain.
Yeah.
And the reason is because you can have products of conception caught in that cervix causing a lot of pain. And if if you pull them out, she'll feel a lot better. So that's why I said, there's caveats, but
And that'll even drop their blood pressure on times. There's this term out there, cervical shock, meaning not spinal shock, meaning uterine cervix shock. When there are products of conception caught in the cervical canal, one, it causes really severe contractions and pain, and two, there's a reflex, sometimes bradycardia and drop in blood pressure with that. I was working in the critical area at Stony Brook, this is about a year ago. They rushed this young woman in who had bad bleeding and was, appeared to be an incomplete abortion on her ultrasound, and they were like, she needs another line, this and that, and I said, can we just quick do an exam? And I pulled products of conception out, and she was like, thank you. And her pressure bounced right up, and everything was better. And they were about to take her to the OR. Then they're like, let's rethink this. So again, there are reasons to look and see what's going on. And the concept of cervical shock is real. I've seen it many times over my 30-plus years. By many times, I'm like 10 or thereabouts.
So we're a little bit behind, and you have to be back at 1:30.
we could do more answers on Slido, yeah?
So
Okay.
we're going to make sure that we answer everything for you. And then, as I mentioned, we do export this to you after the course. So it will all be available. It will still be live for you to access, as will the live feed. But just hang tight for the very last lecture, and we go over all of this with you, okay, on the last day. All right? Please be back at 1:30.
Thanks for your input and interest.
Yes, thank you.
Excellent.